During this presentation, we're going to look at leukemia, what it is, and how we take care of the client with this diagnosis. Here are your objectives. As you see, it talks about DIC, sickle cell disease, leukemia, Hodgkin's and non-Hodgkin's lymphoma, and therapeutic blood products. These will all be provided to you, but each one is a separate PowerPoint. So let's refresh. What are the anemias? It's important to understand what causes them. This is from level 2. Again, another review. Hemophilia. This is a blood clotting disorder, inherited, and you did review this in level 2. Important labs for you to refresh about are the PT and INR. What causes these to be altered, not normal? Maybe medications, maybe a disease state. PT, T, and APTT, a time and a place to bleed. What causes this? This again is a refreshing slide from level 2. Okay, on to leukemia. It's a group of malignant disorders affecting the blood. This is your recorded lecture about leukemia. What is it? How do we take care of the client with this diagnosis? This is a nice pictorial about neutrophils, which are an indication of the presence of leukemia. Here are your objectives. You can see that it includes lots of things like DIC, sickle cell, Hodgkin's and non-Hodgkin's, and therapeutic blood products. You will have PowerPoints that are recorded for each one of these. This one is about leukemia. Here's something for you to refresh. Anemias. You looked at this in level 2, the different types of them and what is causing them. Hemophilia, again, refresh. This is a bleeding problem. This is an inherited disorder, and they're missing factors, so they bleed significantly. Again, refresh. What is PT and INR? What causes it to be elevated? Maybe medications, maybe a disease process. PTT and APTT, a time and a place to bleed. But why? Again, more review. Now, on to leukemia. This is blood cancer. It's a group of malignant disorders affecting the blood and blood-forming tissues of, yes, the bone marrow, the lymphatic system, and the spleen. These all contribute to the production of blood. Leukemia, all ages. You've got dysfunctional cells. Cell division has been interrupted, and it can become fatal if untreated. Now, we thought of it always as a childhood disease, but in actuality, the number of adults affected is actually 9 times that of children. Why? Think about it. Exposure to carcinogens, polypharmacy, comorbidities, and yes, even the aging process. There is no single cause. We look at genetics. Can it run in families? Yeah, it can. Okay. Chemical agents for sure. Viruses. Radiation. You don't have to work in a radiation plant to be exposed to radiation. And immunological deficiencies. So what are those? Autoimmune diseases. They can also cause cancer. What is the pathophysiology? Okay. Too many white blood cells that are immature, and they do not do the job that they're intended to do. So take a look at the sites of involvement. Well, got the central nervous system and the testicles, lymph nodes, liver, spleen, and yes, even joints. How would this client manifest? So, classifications, acute versus chronic. Well, that's determined by cell maturity and the nature of the disease. So, acute, immature, hematopoietic cells. Chronic, mature forms of white blood cells. And that one's pretty gradual. Clients may not even know that they have it. The symptoms are not quite as severe. So the classification is based on the type of white blood cell that is existing. Is it ALL? That's viral. Is it AML? Bacterial. And then you've got your chronic conditions, which is CML and CLL. clients who have CLL and CML do not present with acute symptoms. Now, AML is 25% of all leukemias, 80% of the acute leukemias in adults. That's pretty profound. It's abrupt, it's dramatic. They can have a serious infection, or they can just be bleeding abnormally. How would we know that? Look for bruises. Look for when they brush their teeth. Look when they urinate, as is the blood in the stool. And you've got tons and tons of myoblasts. Take a look at the slide. So the bone marrow and the spleen are growing. So ALL is the most common type of leukemia in kids, 20% of acute leukemia in adults. This one you will see immature small lymphocytes in the bone marrow. And this has to do with B-cell origin. Now, most of the kids present with a fever, bleeding, bruising, they're tired, maybe progressively weaker, and pain. Most of these kids are going to be worked up for meningitis to start with, and then when they do further lab work, they'll say, this might be ALL. Why? Here's the signs. Fever, bleeding, all of that kind of stuff. But the CNS manifestations are pretty common. That's your leukemic meningitis, photophobia, startle easy, even seizures. So CML is neoplastic granulocytes in the bone marrow. They go into the peripheral blood in massive numbers. So think how crowded the intravascular volume is with these type of cells. And ultimately they go into the liver and the spleen. So now what's going to happen? What happens if the liver and the spleen are not working correctly? Well, bleeding, bruising, and inability to fight secondary infections. So think about what your care would involve. Now, CML has a Philadelphia chromosome. That's a genetic marker, and it's present in almost 100% of the CML patients. Okay, their chronic stable phase is usually followed by an acute aggressive phase. It can last for several years, can be well controlled with treatment, but the chronic phase will eventually progress to the accelerated phase. Now, they're going to have to be treated pretty aggressively, similar to that of acute leukemia. Okay, CLL is the most common leukemia in adults. It's got B-cell involvement, and lymphadenopathy is present throughout the body, so that means lymph node involvement. Remember how you would assess for that. Complications from it, pretty rare. Pain and paralysis can occur from the pressure caused by these enlarged lymph nodes. Other things that you may want to think about is where the lymph nodes enlarge. Is it impacting their breathing as well? Because it can. So you would see that as dysphagia, okay, or dyspnea, and it can be pretty serious. Okay, so leukemia, they have different subtypes, but those often overlap with non-Hodgkin's lymphoma. So you've got lymphocytes all over the place, okay? Burkitt's lymphoma might be something that you would see in lymphoblastic lymphomas. But I wouldn't worry too much about that right at this moment. Okay, clinical manifestations, they're varied. It's usually related to the bone marrow not doing well because it's overcrowded by those abnormal cells. So what ends up happening? Take a look at the table 30-24 in Lewis 10th edition. AML, ALL, CML, and CLL. Compare and contrast the clinical manifestations. Good review for you. Okay, so what happens? Inadequate marrow elements cause anemia. How would we know it? Yep, take a look at the CBC. Do you remember your normal values? Thrombocytopenia. Yep, there we go again, the CBC. But we're looking at the white blood cell indices. The composition of the white blood cells. What are they made of? Are there more neutrophils, lymphocytes, basophils, eosinophils, or monocytes? These abnormal WBCs are the problem. These cells then infiltrate the organs, and they lead to an enlarged spleen and an enlarged liver. So now these organs aren't working well. What would you see manifested? What is your care for these patients? So leukemic cells may cause lymphadenopathy. You know what that is, enlarged lymph nodes. Bone pain? Wow. It's suppressing the bone marrow, remember? Meningeal irritation. Okay, so photophobia, again, irritability. Even seizures, oral lesions. How would you know they were there? Well, they may say their mouth hurts when they eat. So what are you going to do about that? Maybe get some of that miracle mouthwash, anything, but they have to get nutrition or they're not going to heal well. They may have solid masses, those are called chloromas. Leukostasis, that's a pretty big deal here. Leukemic white cell count in the peripheral blood is greater than 100,000. That's life-threatening. Their blood gets so thick with all those white blood cells, circulation is now blocked. So what are you going to have? Infarcts in all the organs. Okay, so that we don't want to happen. So to diagnose and classify leukemia, we're going to do blood work and a bone marrow examination. How do we do that? Well, they will actually wash the area. It's usually going to be like the sternum or the pelvic girdle because those bones are flat. They're hollow, when they've got the bone marrow, so they're easy to get to. So they'll wash the area, numbing medicine into the tissue. They'll make a puncture through that bone and aspirate out the bone marrow and look at it under a microscope. That's going to help them identify the cell types and the staging of where the cells are. Is it comfortable? No. Is it necessary? Yes. So you'll have to explain to your patient that, yeah, they're going to be sore. So what are we going to do for that? Well, we're going to treat the pain, help them with repositioning, maybe ice packs to the site. Now, if we're going to look outside of the blood and the bone marrow, because we need more information, yeah, we can do a lumbar puncture. That's getting that CSF fluid. Do you remember talking about that earlier? Position the patient, wash them, numbing medicine to the area. Make sure that they're not on any anticoagulants. Make a puncture through the spinal column, obtain the specimen, and send it off to the lab. But your care doesn't stop there. They have to be flat. Remember that it takes approximately 72 hours to have the body take all the fluid that you're drinking or IV fluids and turn it into cerebrospinal fluid. So they have a lack of it. How does it manifest? Dizziness, headache. So we keep them flat. We give them fluids. We give them drinks that are vasoconstrictors, Mountain Dew or Coca-Cola. Fill them with fluids and tell them to lay flat. If they get a CSF leak, how do we know it? We have a headache that's worse when they raise their head, when they sit up or stand. And maybe we'll see a CSF leak because we looked at their gown, we looked at the sheet. How do they fix that? Well, 72 hours, they'll do something called a blood patch. They'll get a blood specimen from a vein and stick it in the hole where the leak is occurring, and they start the process of laying still for 6 hours all over again. We may do a CT scan. What does that do? Well, they have to lay still, and it's going to tell you how much involvement there is going on. So what's our goal? Get them into remission. So their prognosis is related to their ability to maintain the remission. Now, people will go out of remission. Okay, the more times that they go out of remission and we have to redo the chemotherapy, it's going to be tougher each time. The side effects will be probably worse because the drugs are stronger. Prognosis, the more times they fall out of remission and have a relapse, the worse the prognosis becomes. Now, staging of chemotherapy. You're not going to deliver the chemotherapy as a nurse generalist, but you need to watch for the side effects for your clients, okay? Induction, post-induction, and maintenance, okay? The big deal here is clients have to be aware that these things can happen, okay? They will be in protective isolation. It's important. You're going to be monitoring that. Yes, they have to have good nutrition, but we're certainly not going to bring them fresh fruits and vegetables, are we? Are we going to monitor their vital signs? Are we going to monitor their lab results? You better believe it. Sometimes even the smell of food can make them sick. Nausea is a big deal here, so anticipate it. You will be administering antiemetics to them. Activity, maybe they can't tolerate it. Again, watch for those secondary infections. Now, induction therapy, let's start them, get them into remission. These people can become very, very, very sick. They're going to be in ICU during this phase. Now, post-induction or post-remission chemotherapy, again, this is high dose. These are drugs that target the cell in a different way, and the whole goal here is to attack those cells in any way that we possibly can at their different stages of development and get them into remission. Okay, so we want to eliminate the remaining leukemic cells that we can. Maintenance therapy, they're the same drugs, but they're given every 3 to 4 weeks. But these people have got to keep following up with their physician to make sure that things are going the way they want them to. Okay, combination therapy is something that is common. Why? Well, for 3 reasons. If we give different combinations of drugs, we decrease the drug resistance. The body will develop that. We will decrease drug toxicity, and we can interrupt the cell growth of these bad cells at so many different levels. So the use of this targeted therapy is important treatment. Cure with these therapies alone, it's rare, unfortunately. So what else do we do? Corticosteroids. These are pretty high dose corticosteroids. So what are you worried about with those? Well, elevated glucose is the first thing you're going to say. But they're there to reduce the inflammatory response that is set up by the administration of all of these pretty tough drugs. Watch for gastric ulcers. Watch for bleeding ulcers. These people should probably be on proton pump inhibitors or H2 blockers too. Now, they may end up with total body radiation. And they would do that in preparation for bone marrow transplantation. This is a pretty big deal. The whole body is radiated. They have absolutely, positively no defenses against infection. So they are in very, very tight protective isolation. You don't enter in that room without being, without an ability to protect them. You limit visitors. Labs are watched very, very closely. If they have to go out of the room, hopefully they don't, you better put a mask on them to protect them from the environment. They can't even eat off of dishes. Their meals are brought into an anteroom on paper plates and stuff, so there's decreased risk of passing infection that way. So, other things that can happen would be immunotherapy and targeted therapy, and that's genomics, and that's coming a long, long way now. They will identify that cell and develop something to treat that cell specifically. Okay, stem cell transplant. Here we go. Eliminate the cells using combinations of chemo with or without the total body irradiation. So, again, these are the people that we have to be so careful with them until they get their stem cell transplantation. Now, how does this happen? They have to be the donor has to be HLA matched. It can be a sibling, volunteer, identical twin. Or we can, before anything happens, we can pull out their stem cells and then good ones, okay? And then we can give them back after all the other ones are killed off. But this is a big risk for infection, relapse, okay? So, what is our assessment? Again, the same stuff that we've been talking about before. What have they been exposed to? Do they have some genetic predisposition or abnormalities? Have they had frequent infections? Have they had previous chemo? Have they had previous radiation? Okay. Functional health patterns. Did they lead a risky life? Here's your objective data. Kind of your dress the skeleton. How would you know these things were going on? What nursing care measures would you put in place for these? Now, the diagnostic findings are kind of funny here. Do you remember looking at ant, anemia, neutropenia, and thrombocytopenia? Lots of white blood cells that are immature. They're like ants in a big ant colony. But those white blood cells may be normal or abnormal. H&H is down, thrombocytopenia, everything's down. Philadelphia chromosome. Boy, that's something that's unique, isn't it? Okay, and their bone marrow aspirate or biopsy may reveal hypercellular growth. So our goals, we want our client to understand and adhere to their treatment plan. We'll do our best to minimize their side effects and complications of the disease. Keep hope alive. Establish small goals. Make sure they feel supported during periods of treatment, relapse, and remission. There's an awful lot of physical and psychological needs because cancer brings great fear to the mind. People are scared they're going to die. Family can need support at this time too. Maybe it's a financial burden. Maybe this is the wage earner. Help them to be as much as they can be. Participate in their own care. Give them hope. And if they want to talk, there are cancer support groups. There's leukemia support groups. Put them in touch with people that will listen to them, people that have maybe been there before. Maybe spiritual help is a place. So the diagnosis of leukemia can bring with it the need to make really difficult decisions when they're under so much stress. Now, people will be empowered by knowledge of their disease and of their treatment. So get your interprofessional team up and running. Make sure you're very cautious reviewing all drugs, okay? Be prepared to manage that life-threatening side effects of the treatment, due to that bone marrow suppression. And again, assess the effectiveness of drugs. Watch for peaks and troughs on drugs. Watch for side effects. Watch for contraindications for taking a drug. You're the patient advocate. So, drugs, and drugs. Trend your labs. Notify your physician of any changes. Teach the patient, but also teach the caregiver. They have to stay on top of their disease management. They will follow up with their physician for years. Tell them when it's really necessary for them to go see the doctor, make an appointment. Okay? Rehabilitation will be a part of it. They will be pretty weakened. They may need physical therapy, occupational therapy. Again, psychosocial, social, and spiritual. Vigilant follow-up care. That doesn't mean just going to the doctor. It's also maybe some vocational training, maybe immunizations. Maybe they need some counseling about can they have a baby? Should they father a baby? Probably not the best idea. So what do we expect? We expect them to manage, cope with the diagnosis, cope with the treatment. Hopefully no complications, but feel supported throughout their whole treatment. It's a journey. Here's a case study for you. WC is a 64-year-old man with complaints of general fatigue and recent weight loss. So, you're the intake nurse. What information will you be sure to obtain? Okay, all those things we talked about. What is his previous health history? Has he had a lot of repeated infections? Has he had a personal history of having cancer or chemotherapy? Has he been exposed to toxic chemicals or radiation? What does he do for a living? Where has he lived? Does he have a fever? GI problems? What are his actual symptoms? Well, the physician's going to order a CBC for him. White blood cell count is 110,000, hemoglobin 10.5, and platelets 120. Which of these are abnormal? What are you going to do about it? Well, that WBC count doesn't look very healthy, does it? And the hemoglobin's a little bit low. Platelets look like they're okay, maybe a little on the light side. So you better know your lab values. What do you think? So this guy's wife comes to the next appointment to find out results of all his tests, and she's really worried. So what is the primary nursing management for this guy and his wife? Well, help them understand what the diagnosis means. And do a lot of teaching about the disorder and the treatment options. Now, you're not alone here. Your physician or their physician is going to do a lot of talking with them, but you'll have to reinforce that, remember? So his results indicate that he's in the early stages of CLL. What would you teach him about follow-up care? Well, he needs to make routine appointments with his doctor. He needs to get prompt treatment if he has a fever, if he has any infection, or an increase in his current symptoms. His decisions with which way to go with this are his decisions, and they have to be honored. But he'll need guidance as to what these treatments are, what the side effects are, and what he can expect. Well, that's the end of this recorded lecture. So, I'll be talking to you. Bye.